and welcome to Module 4 of the Assist to Succeed Dental Assisting curriculum. Today we'll be discussing amalgam and composite materials and instruments, along with a few other particular items. I'm Dr. James Drake. I will be your host and your narrator for today's module. So let's do a quick review as we do at the beginning of each module. We try to review what you've talked about in the previous module. You will most likely come across one of these two types of X-ray sensors. The hard sensors, they go in a plastic shield, phosphorescent plate go in a disposable slipcover and are sealed so that this little blue plate can be reused over and over again. And obviously the hard sensors are reused over and over again with the replacement of the barrier there. So, and I want you to, again, think about the bisecting angle technique. So this would be using the Rin cone. The bisecting angle, once again, is the angle of the angle between the film and the tooth. You split that half in the middle, and then your PID should, your positioning indicating device, or the tube, the X-ray tube head, should be parallel to that angle. Okay, same thing here in the incisor region, maxillary molar region, mandibular molar region. Okay, and a little review of why we take bite wings, so that it decreases the number of X-rays that are required. It allows us to open those contacts up really nice and see in between those teeth. And back to numbering teeth. I'm going to keep bringing this up over and over and over again because you have got to know your teeth numbers. I hope by now, being the fourth module, I hope by now you have memorized your landmarks and you go from there. The landmarks being 3, 6, 11, 14, 19, 22, 27, and 30. Okay? So I hope that all those landmarks are obvious to you now and you can count forwards or backwards from those landmarks to find your tooth numbers. Anatomical features, this would be the tongue, soft palate, hard palate, incisors, premolars, molars, pteromandibular raphe. Here's some new ones for you, just for interest's sake. This would be the maxillary tuberosity. If this patient had no teeth back here, this would be the retromolar pad. This is the lingual frenum inside here. The labial frenum. Labial frenum would be underneath the lip here. You cannot see it, but it would be underneath there. Okay. Where are the buccal surfaces of the teeth? Buccal, 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 buccal. The distal, where are the distal surfaces of the teeth? So the premolars are distal to the canines. Distal to the canines, away, distal meaning away from the midline. Here's the midline. Anything farther away from the midline. So the molars are distal to the premolars are distal to the canines. Pteromandibular raphe, I already mentioned that. It's right there. Lingual surfaces. Lingual, what does lingual mean? Lingual has to do with language, the tongue. So it's on the tongue side of the teeth. Soft palate, mentioned that earlier. Hard palate. Where are the mesial surfaces of the teeth? If I put my pointer here, which tooth is that the mesial of? What's the mesial of both of those teeth? Here, the mesial is here, and it's the distal of that tooth. So distal of 8, mesial of 7. Distal of 7, mesial of 6. Distal of 6, mesial of 5. Okay, so we're going to get into restoring teeth. Restore would mean return to health. Dentists often use loops. It helps improve their posture. It helps them see better. So instead of seeing 5 or 6 teeth at a time, they might only see 1 or 2 teeth at a time. It's pronounced loops with 2 O's, and I do that as a little memory trick so that you can remember what they're called. Some loops have headlamps and some do not. So there's your little memory trick for loops. A normal view without any magnification, what a dentist would see with low power loops, and a really high power loops or microscope, the dentist might be looking at something like this. So this tooth right here, this premolar, might look like this through the dentist's loops. So it helps them get up close and personal with the tooth and see a lot better. So again, just to review, some loops you'll see hygienists use them, some dentists, and they may or may not have a headlamp. There's some limitations with loops. They do require more light. The higher the power, the more light they require. That's why headlamps come in handy. And there is a blind spot. The dentist cannot see very much outside the loops, and he's going to be focused on the tooth. So the dental assistant should be aware of that, because the dentist may not see the patient's eyes squeezing shut or hand raising and things like that. So dental assistant's really important to help the dentist see what the patient needs are. Okay, so amalgam filling replacement. So amalgam is a word that means a combination of metals, or a combination of different things. And in fillings, it's a combination of metals, mercury and zinc and a whole bunch of other different metals all mashed together that create this metal silver filling. Okay, so that's one of the many most common restorations that were ever been in use is amalgam fillings, and they are still in use somewhat today. Mostly we see them primarily in pediatric patients, but occasionally you will find dentists still using amalgam fillings in adults. So, some basics: cotton pliers, mirror, and explorer. You'll notice the explorer has a little shepherd's hook on one end. This one has just a little crook on this end. I don't even know the name for that, but this is what we would call a shepherd's hook. Cotton pliers, mirror, explorer, and then articulating paper holder. So articulating paper is what the dentist uses to determine how the teeth are coming together, and that paper needs to be held firmly. Things I want to point out is this articulating paper is not sticking out the back at all. It's right along the edge there, and it's not hanging over the top, and it's not underneath the top, meaning it goes right to the very end. It's not too short, it's not too long, it's not sticking out the end. It's right at the edge, those two edges of the articulating paper holder. That is important. It helps things work a lot better if you load it just like that. Wooden wedges, we often use those. Sometimes we'll use plastic wedges. I've switched back and forth between wooden and plastic from time to time. Right now I'm using plastic only. Matrix bands, or I had a universal band or a molar band with a lip or a dip. Some people call it a lip, some people call it a dip. And then this is the Tafelmeyer retainer, which I hope by now your instructor has exposed you to. These are, they can be very tricky for dental assistants. For some reason, the Tafelmeyer retainer can be very difficult for many assistants to understand. So the best way to learn to understand them is to just pick one up and start playing with it and figure it out how it works. So loading the retainer, this is an important thing. You'll notice that the matrix band is bent. It's curved. And so when you fold it in half, that curve becomes a narrow loop. So it has a narrow end and a wider end on this loop. And you'll see that here in just a moment. But again, this is something you really should pick these up and experiment with them. So hold the band up as in a V in the slot of the retainer, as you see here. Fold the V-band without crimping it. I hate it when I get a crimped, smashed matrix band from an assistant. It needs to still be round here, so don't squeeze it so hard that you mash it together. You can see here it's still in a nice loop. That works out great. So allow the folded end to extend just beyond the edge of that retainer. And then you tighten the end knob, that's this one here, in order to capture the ends of the matrix band in this little slot here. We'll watch a short video on that.
Examine the outline of the cavity preparation using a mirror and explorer. Determine the size of matrix band to be used for the procedure. The band is selected according to the size of the tooth and depth of the cavity preparation. Place the middle of the band on a paper pad and burnish this area with the burnisher. Bring together the ends of the band to identify the occlusal and gingival aspects of the matrix band. The occlusal edge has the larger circumference. The gingival edge has the smaller circumference. With the diagonal slot facing toward you, slide the joined ends of the band, occlusal edge first, into the diagonal slot on the vise. Guide the band between the correct guide slots. The position of the band in the guide slots depends on if the tooth being restored is maxillary or mandibular, right or left. Position and seat the loop over the occlusal surface with the retainer parallel to the buccal surface of the tooth, making sure the band remains beyond the occlusal edge approximately 1 to 1.5 millimeters. The band is held securely in place by finger pressure over the occlusal surface of the band. Turn the inner knob clockwise slowly to tighten the band around the tooth. Use the explorer to examine the adaptation of the band. At this point, the proper wedge will be selected.
Okay, so again, the best way to learn the Tafelmeier assembly is to just pick it up and work with it. So that might have been somewhat confusing, but once you understand it, then it will make sense. So picking up the Tafelmeier and utilizing it's the best way. So I put this little picture up here to remind us that we're talking about amalgam materials, and we're only going to talk about this briefly because, again, some of you will encounter placement of amalgam fillings, but most of us will be experiencing removal of amalgam fillings. So sometimes amalgam fillings can cause a lot of hot and cold sensitivity because they're metal and it conducts heat and cold very well. So a lot of times dentists will put a insulator underneath the filling. They'll put it down first before they put the filling in. And one popular one is Dical. This is a brand name. And you put out equal amounts of each kind and then mix it and then use this, what we call the Dical instrument. It has a little knob. It's very difficult to see in this picture, but it has a little ball right on the very end so that it picks up the material, and then it can be carefully placed on the tooth area. These are amalgam capsules. They require a special machine to shake the capsule back and forth and mix the amalgam together. Then these little capsules are broken open and dumped into the amalgam well. This is another liner that's sometimes placed. Because the amalgam isn't necessarily super strong in certain places, and it needs something to grip the tooth. It doesn't bond to the tooth, so it just needs to have something to grip onto. Pins are often used with amalgam fillings. So the pins are used where there's little tooth structure left. You drill a little pilot hole with the drill, and then the twist drill is put in the latch piece, handpiece, the slow speed handpiece, and then the pin is placed and it'll fracture from this little plastic automatically when it's at the right depth. So they're pretty simple to use. So this is the pilot drill. I'm going to make a little hole, and then the pin goes in, and as it goes in, and when it bottoms out, it breaks off from the plastic automatically. So the pin remains there. And it acts like rebar inside of concrete is pretty much what it makes. So if this rebar is the pin, the composite or the amalgam filling is the cement that flows around it. So this would be like the rebar, and then we're going to put some composite or amalgam filling around that rebar. So it goes in this special machine that I mentioned earlier, and it shakes back and forth really fast. It makes a lot of noise, and it shakes really fast, and it mixes all those metals together. And sometimes it's 20 seconds or 30 seconds, it just depends on the product. So then the amalgam is dumped into the well, as we mentioned earlier, and then you have this little amalgam carrier, which you smash the amalgam into that carrier. So here's a quick video about that.
Activate the amalgam capsule if indicated. Place the amalgam capsule in the amalgamator and adjust the setting for the type of amalgam being used. Close the cover on the amalgamator and begin trituration. Remove capsule, twist open, and dispense amalgam in well. Fill the small end of carrier first, and transfer carrier to the operator, making sure the end of the carrier is directed toward the preparation. Continue this process until the preparation is overfilled.
Okay, so the amalgam carrier, and you're going to use the condenser to mash the amalgam down in there, or the dentist will rather, not the assistant typically, and then a ball burnisher or football burnisher in order to shape and polish the composite. You might have to carve it a little bit. The dentist may carve with a discoid, cleoid, or a spoon excavator. There's, just depends on the dentist and what he or she chooses to use. An amalgam tub tray setup's pretty simple. There's not a lot to it. Amalgam fillings are pretty inexpensive and simple to place. That's why some dentists still use them today. This is incorrectly placed. You would never see a Tafelmeyer put on a tooth like this, and I put it in here because this is incorrect. I want you to see what incorrect would be. This would obviously be poking out through the patient's cheek, so it should be in the slot on this side of the amalgam, or sorry, the Tafelmeyer, and then it would be pointing towards the front of the patient's mouth. So this wedge is going to go in between the teeth to help hold that matrix up against the tooth. So looking here, the wedge has now been placed, and it's holding the matrix against the tooth. And then when you're all finished, the amalgam would look something like this. And the black spots here are the articulating paper that I mentioned earlier, and that's how the dentist determines that the biting forces are not on the amalgam, that they're on the tooth, the tooth's cusps. So the reason why amalgam fillings stay in is because they're wider at the bottom than the top. If they're not, then they need those pins, that rebar that we mentioned earlier. So if I were to cut the tooth in half and look at an amalgam filling, you might see the pulp, you might see a little the Dical liner that was here, you might see a liner of the copalite, very thin layer that's just right here, you can barely see it on the outside, and then you may the dental amalgam. Okay, so we're going to move to what you're far more likely to spend most of your time doing as a dental assistant, and that's composite fillings. Canadians pronounce it composite, just whatever is correct for your particular area. But in America, it's typically called a composite. I guess for those who are offended by that, I should say in the United States, because Canada is part of North America. Okay, so pay close attention. If you work for a general dentist or a pediatric dentist, it is very likely that you will do more composite, much more composite filling than any other procedure in dentistry. This is something you will expect to do every single day that you are a dental assistant, is a composite filling. Okay? So you will probably use a Tafelmeyer or some sort of matrix band. You may use a clear matrix band, especially for anterior teeth. So you might use a compositite assembly, and it has many parts. So it has matrix bands and wedges and rings and pliers for the rings. And when it's all put together, you can see the metal matrix band is here, the wedges are here, and the rings are here. And the purpose of the rings are to help hold the matrix band in place and squeeze the teeth apart a little bit so that when you remove the matrix band, that the teeth are actually touching each other, so there's good contact between the teeth. Sometimes a glass ionomer is sometimes used as a base underneath the composite fillings to prevent sensitivity. We use that dical underneath amalgam fillings. You can use it under composite fillings, but usually some sort of glass ionomer. And it's not important that you understand what a glass ionomer is, but you should know that term, because some dentists will say, well, I'd like a glass ionomer to go underneath that. And that's just a fancy word for a insulator that goes underneath the composite fillings. So again, we might also use dical, but usually when I use this, I'll use this when I'm close to the nerve, and then we'll put this glass ionomer over the top of it to insulate it and protect it from the rest of the filling material. So post-op, so post means after, and op means operation or procedure. Post-op instructions given after the procedure. Okay. Post-op sensitivity. It's very common with amalgam fillings because of the metal that conducts heat and cold very well. So a tooth can be traumatized when it's been worked on, and then when it has a metal filling placed in there, that the nerve can be very upset by that. So here's an example of where much of the tooth is missing. A base and a liner is placed, and then a base over the top of it, and then filling material over the top of that. But that nerve can be really upset by having all that stuff close by. So using the insulators and liners and bases helps a lot. Okay, composite bonding agents. So the way in amalgam filling, if you can remember, amalgam filling was wider at the bottom than the top, so it can't remove itself from the tooth because it's wedged in there essentially. Composite fillings are not like that. Composite fillings are microscopically bonded to the tooth. So it's almost like they're glued to the tooth. And there's many different ways to do that. A lot of times the bonding will require an etching agent, a bonding agent. It might require mixing wells if things need to be mixed together. Usually it requires these little micro brushes. And there's many different products out there. So I'm just going to kind of give you the basic idea, and then every office is going to have their own preferred bonding agent. Some will be 1 bottle, some will be 2 bottles. Some will use a etch that comes out of a little syringe. Some of the etching will be done by the single bottle or the double bottle bonding agent. You don't need to know the specifics until you start working in an office, and then they will teach you the specifics of the bonding agent they want. But I need you to understand the concept of bonding and bonding agents. Here's another system that requires a etchant that comes in a little syringe, and then it's called one step. So that kind of gives you an idea that there's probably not 2 bottles for this particular bonding system. Some dentists prefer the acid etching in a syringe. Some, it's the bonding agent itself is the acid etch system. So this is usually 37% phosphoric acid. It won't burn you, but it might damage your clothing. So if it gets on the skin, just wash it off. It's not super dangerous that way. But when it sits on a tooth for a while, it will make little microscopic holes, or not necessarily holes, microscopic roughness to the tooth, and that allows the bonding agent to bond better. So here's some examples of different bonding agents. This one is called Clearfill SE. It's very popular. Simplicity. This one's very complex. It's got lots of different steps to it. Prime and bond. There's just several different kinds, and they're changing all the time. So again, you just need to understand the concept of bonding a composite filling to a tooth. a very important concept that you need to understand when you're working with amalgam fillings, saliva doesn't necessarily matter so much, but when you're working with composite fillings and bonding, you need to know that saliva kills bonding. It eliminates it. A filling material will not bond to tooth structure if saliva or water contaminates the bonding agent. And you get this little brown line that you see down here on these in this picture. So I leave that picture there because we're going to walk through some steps here. That brown line indicates a failing composite, and it must be bonded or it will be painful. It'll get cavities around it. It'll fall out. It's just a real problem, and that's why sometimes dentists still use amalgam fillings for simplicity sake, is because amalgam fillings are much easier to place than composite fillings. My dental assistant must make absolutely sure that no saliva, blood, or water contaminates the preparation, meaning the tooth is prepared and a hole is made in the tooth where the cavity was. That preparation, once it's clean and dry, needs to stay clean and dry until everything is done with the filling. So remember, saliva kills bonding of composites and sealants. You need to know that too, because assistants in many states can place sealants, and the sealant must be free of saliva, water, or blood in order to make sure that it bonds properly. So curing lights are mentioned. So composite filling is like a putty when it goes in, and then when a blue light is shined on it, it hardens into a tooth-like structure. And there's many different kinds of curing lights. This one here is a rather older one, but you might still see it around. Most of the time you're going to see something that looks like this or this or this. These are LED curing lights. There are some of these still hanging around, and then there's a few of these. These are called plasma arc curing lights. They're really nice lights, but they're not as popular as the LEDs. But every dentist will have their own preference and reasons why they're using what they're using. So you just need to understand the principle of light curing. It's very important. It's a very important part of the composite resin filling, is you've got to cure that material and cure it well. So here the assistant's curing brackets on the teeth for braces. Things to remember about curing: get close. The farther away from the material, the less your light will work. And so every millimeter counts. The closer you can be, the better the cure. The light should turn on for just like literally half a second before the tip actually touches the material. If the dentist spend 10 minutes sculpting and shaping and beautifying this tooth, and then the assistant comes along and smashes it with the curing light, that doesn't make anybody very happy, patient nor the dentist. So the light should turn on just before it touches the composite. So you're trying to get super close, turn the light on, and then you can get super close, because that top layer cures in an instant, and so you won't ruin the shape of the material. So get close is the first concept. The second concept is aim directly. You want to be aiming directly at the material, not from an angle if at all possible. The end of that curing light needs to be at a perpendicular angle, straight up and down to the filling material. And the third concept is to remember that you've got to cure long enough. A short cure time will set up a composite to fail, and it might be very painful for the patient if it's not cured. So most lights will be about 5 seconds. Some could be as long as 40. You just need to ask the doctor, how long would you like me to cure? And there should be a setting on your instrument that'll tell you how long it's going to cure. So familiarize yourself with the curing lights that the office you work in has. Sometimes dentists will use sandpaper strips or discs or brushes or cups or a number of different things to polish. Every office is going to be a little bit different in that regard as well. Composite, the putty that I mentioned, sometimes comes in little twisty syringes. You twist this and you can see it's threaded, so as it's twisted, the putty squishes out the end. This one, dentists might ask for a shade guide so they can pick the correct shade for that particular tooth. And again, I put this picture up here to remind you what we're talking about. We're talking about composite fillings, not amalgam fillings. And you can see they did a nice job selecting a shade for these teeth. And then this is a composite gun and composite compules. There is such a thing as called flowable composite. Rather than being putty-like, this is more liquid-like. So it flows easier, and it might be used underneath as a first layer. I personally don't recommend that, but some dentists might be doing that. So you just need to be aware that's a possibility. You also need to know that it's very runny, so it can squirt all over the place, so be careful with it. Self-cured composites, they would be mixed together in either a mixing tip, or sometimes the assistant is required to scoop a little bit out of two different parts and mix them together, a catalyst and a base. But these can harden very quickly, so you need to be aware of how those are used. And I would use them without a patient before I was asked to use them with a patient, if at all possible. So instruments that you might use in a composite filling: a mirror, an explorer again, cotton pliers, die-cal instrument, and this is called a plastic instrument because it's used to shape plastic materials, not because it's made out of plastic. Different offices may have different names for this. I call this a flat instrument because it's flat on the side. But again, many dentists might call it a plastic instrument, not because it's made out of plastic, but because it's used on plastic or formable materials. So composite tubs considerably more complex than an amalgam filling tub. There's more materials, more things to do. So again, composite fillings are harder to do. So the general composite procedure: generally you're going to etch, bond, cure, place the composite, cure, and then finish. So those are your basic steps. So this would be etch, bond, cure, composite, cure, finish, and polish. Etch the prep, bond, light cure, place the composite, light cure the composite, and polish the restoration. Every dentist will have his or her own method of polishing and finishing the composite resin restoration materials. You'll just have to get familiar with the office that you work in, because there's many different types and methods. Sanding discs are very common, but I need to repeat this again, that saliva kills bonding. It's really important you get that, you understand that, and you do not allow contamination of the bonding once it's placed. So the dentist cannot leave a patient breathing on composite filling, or shouldn't, once the bonding is done. The filling should go in immediately. So it's really important that you keep that restoration isolated. Saliva kills bonding of composites. And I hope we haven't belabored that point too much. I don't know if it's possible to belabor it too much. You need to remember that and understand that. Okay, so this is a long video describing a cavity restoration. It's about 20 plus minutes. Yep, 21 minutes. So I'm going to let you enjoy that for a little while. You're going to kind of get to see a composite filling from start to finish here. Okay, so the first thing you want to do is place topical anesthetic. The assistant might be required to do this for the doctor. In this case, the doctor is going ahead and doing it. But the topical is placed gently using a cotton swab over the site of the anesthetic. The words shot and needle are not used in the operatory, as we want to minimize the concern from the patient. The doctor or the hygienist now applies the anesthetic. Again, we don't use the words needle or shot. If we can avoid it, we like to use the term anesthetic, or for small children it would be goofy juice or sleepy spray or something very friendly. Immediately upon completion of the anesthetic, because it tastes very bitter, the assistant approaches the patient and informs that they are going to rinse their mouth, and then rinses them very well, spraying the back of the tongue with air and water, and then allowing the patient to rinse as many times as they need. Next is the insertion of some type of bite helper or bite block. In this case, it's a malt prop. There are many different kinds. Some go inside the mouth, some go outside the mouth. It just depends on the preference of what you and the patient are happy with and the doctor is used to. This just helps the patient's jaw not get so tired as they don't have to pull their mouth open. So again, note the position of the instruments, the handpiece, the direct view of the doctor to the mirror, the suction tip, and the air-water syringe tip. Okay, so now I want you to notice the assistant. As soon as the doctor stops operating here for a second, the assistant blows air up in the prep so the doctor can see, blows the doctor's mirror off, blows the prep, blows the mirror, blows the prep, and then the doctor resumes prepping. We're using the high speed. There's no rinsing that's needed because the doctor is continually rinsing with the water spray from the high-speed handpiece. Now I want you to note the body position of the assistant. Her back is straight, her elbows are at a 90-degree angle, her neck is generally straight. And as we resume the prep here, again, just note the position of the instruments and how little the assistant moves. The assistant moves only to adjust to the doctor's position. The doctor will rotate the mirror now and again. As the doctor leaves, the assistant immediately washes and dries the prep and then suctions the corners of the patient's mouth to eliminate the problem of water building up in the back of the patient's throat. Then the doctor re-enters the mouth and resumes prepping. One of the biggest mistakes that the assistant makes is assuming that when the doctor is done, the assistant is done. In fact, that's just the opposite. When the doctor is done, the assistant moves in, washes, rinses, dries, suctions the patient's throat, and gets the area ready for observation by the doctor. So as soon as the doctor is finished, it's now the assistant's patient, and the assistant should take over and prepare for the doctor to return. Again, note the positioning of the patient, the doctor, and the assistant. This is a view from the assistant's point of view. Notice the air-water blowing, or just the air blowing right over the mirror to eliminate the water spray from blocking the view of the dentist. The high volume suction, in this case, is underneath the mirror. And again, the doctor leaves and the assistant moves in and air water the prep. Now we're going to look at the view from the doctor's point of view. As you can see, he's looking down in the mirror as he observes the preparation. The air water syringe is there to blow the high-speed handpiece water off of the mirror so the doctor can observe the preparation. As we near the completion of the use of the high-speed handpiece, again the assistant rinses and dries the preparation. The assistant then suctions the opposite side of the mouth and the corners and eliminates too much water from going down the patient's throat. The doctor now switches to the low-speed handpiece, and we're going to observe this primarily from the assistant's perspective. You'll note the position of the air-water syringe changes slightly. The mirror is the same and the high-volume suction is the same, but the air-water syringe is now blowing up into the preparation, not in front of the mirror, but blowing up into the preparation to eliminate the sawdust or tooth dust, as it were, from the preparation so the doctor can see. Again, rinse and dry at this point using a low speed. Instead of just air, you need to rinse and dry to eliminate all the sawdust from that area. Most often you'll need to use air and water both at the same time when rinsing. Again, note the position of the air-water syringe relative to the handpiece. It's now no longer blowing on the mirror, but up into the preparation to eliminate the dust from the tooth so the dentist can see. The low-speed handpiece presents a considerable amount of vibration inside the patient's mouth, so it is often good just to say to the patient, a little bit of vibration here, and that gives them a general warning that there's going to be some bumpiness associated with the low-speed handpiece. We often use the words, "This is Mr. Bumpy" with the children, and that helps them understand that he's a little bit of vibration. Again, once the doctor leaves, the assistant must immediately rinse and dry the preparation, suction for the patient, and then they can leave the mouth. And just a quick view of the finalized preparation. Notice we prepared both the teeth that we were planning to restore before we restored them. The next step is to create a wall between the tooth that we prepared and the tooth that is been unprepared. This wall is often created by two different methods. Most popular are the Toffelmeyer, and the second is the compositite, or some variation on the compositite system, which you're seeing here. The doctor has placed the matrix, which is the wall essentially between the two teeth, and he's also placed the wedge in order to hold the matrix in place and create a tight seal between the gums and the filling. The bands are to spread the teeth slightly apart so that the thickness of the matrix doesn't leave a space between the two teeth. It is important that the contact between the two teeth be tight so that food does not get stuck in between the teeth. This part of the procedure is very important. The doctor may have the assistant place the matrix. That is appropriate in some states. In this case, however, the doctor is placing the matrix himself. He's burnishing the band slightly so that he makes certain that it is up tight against the adjacent teeth. This is what it looks like once it is complete. This is just for one tooth. We're just going to complete one tooth at a time with the restoration. Once the matrix is in place, the doctor rinses and dries the area very well to make certain that it is clean and sealed and that he is able to maintain a dry field while placing a composite restoration. The dry field is not so critical with an amalgam restoration, but with a composite restoration, the area must be free from saliva. Here the doctor is placing the priming agent. There are many different products used to bond the filling to the tooth. We're not going to cover all of them here. There are just too many to cover. You will get used to the one that your doctor likes and trusts very quickly. They are all very similar in their application. Some require more steps than others, but generally a dry, saliva-free field and these microbrush applicators are pretty universal. The doctor in this case wants to air dry the priming agent, and then he places the bonding agent, and then the assistant will hand him the composite material while she light cures the prime and bond. As we go along here, you'll notice that the assistant never leaves the doctor's hand empty, or very rarely does. She always has the next instrument to place in his hand so that there's no wasted effort. He's using a small condensing instrument to make sure that the composite material, the first layer of the composite material, is down tight against the tooth. then the assistant will return to him the composite material after a light cure. So watch for the light cure to come first and then more composite material. The light cure. This is a fast light cure using a plasma arc curing light. There are different types of curing lights. Some require up to 40 seconds to cure. This requires between 3 and 5 seconds, depending on the material and the procedure. Memorizing the steps of a composite filling may be difficult before you are working in an office, but once you've done the procedure a couple of times and gotten your hands in there and working, getting some muscle memory going, the procedural steps will come. It is important for you to be anticipating the next step. Notice the assistant has the next instruments ready as the doctor is completing the shaping of the filling. Although light cure is the next step, the assistant has a gauze there to remove any excess composite instrument, and the curing light is within easy reach, so she can immediately place it as soon as the doctor has completed and called for the curing light. The curing light needs to be applied very close to the tooth, as close as possible. The farther away the curing light is from the tooth, the less effective it is. The doctor now removes the compositite bands. He will then remove the wedges using a hemostat or a cotton pliers. Once this matrix is removed, the assistant will then re-enter the mouth and cure again to be certain that the composite is cured completely. Some doctors may prefer this, some may not prefer it. Again, don't worry too much about the particular steps, just get the general ideas down for now. Particular steps will come as you sit chairside with the doctor. The doctor now uses the high-speed handpiece to shape. Typically, this is not done with air-water, although the preference of the doctor may be to use water during the finishing steps. Notice the way the assistant is holding the high-volume suction, and the positioning is generally the same as for the preparation. Air over the mirror and high-volume suction to eliminate any water or dust that may be coming off. I just want you to note the position of the assistant's body. She's working on the assistant's bracket table and preparing the bonding and the priming material. She then presents the instruments to the doctor. Again, notice her posture. Her back is straight, her neck is straight. She has easy access to all the instruments and can present them to the doctor in a comfortable, efficient manner. Things to note: if the doctor and the assistant were standing side by side, this assistant is considerably shorter than the doctor. However, her head is higher in this position than the doctor's because her chair is much higher than the doctor's. Her feet are comfortably resting on the footrest that is associated with a assistant stool, and her elbows are resting on the armrest of the assistant stool. It's important to consider ergonomics as a dental assistant. Your back and your neck can become extremely sore if you're not positioned properly and not using your equipment properly. However, if you are using your equipment properly, you can enjoy a long, rewarding career. So note the straightness of the assistant's back and neck, that she's able to reach all of her instruments comfortably without stretching or going into unusual and contorted positions, that she's able to reach everything comfortably and move quickly and efficiently to complete the restorations. The comfort of the patient is also very important. The patient should be positioned with their head slightly above their chest so that all the blood doesn't rush to their head. And the nitrous oxide used in this procedure should be monitored and adjusted as needed for the comfort of the patient. The majority of the procedure is now completed and the doctor prepares to adjust the occlusion for the patient. The prop is removed and a gentle massage of the patient's masticatory muscles is given, some Vaseline applied to the lips, and the patient's comfort is, again, first and foremost throughout the procedure. The articulating paper, as viewed from the assistant's perspective, the patient is asked to gently tap or grind on the filling, then the doctor adjusts. Note the assistant may use the air-water syringe, and depending on the amount of adjustment, may also use the high-volume suction. The doctor continues with the adjustment. This may be once or twice, it may be many times. It just depends on the filling. The assistant should always be prepared to blow dust off the tooth and prepared to re-enter the mouth with the articulating paper in an efficient manner at any time. Once the doctor is satisfied that the adjustment is complete, then he will begin the finishing process. The assistant may be required to do the finishing and polishing of the composite restoration or the other type of restoration in certain states. Again, a rinse and a dry and a suction. This is a completed restoration of one of the teeth. Once the restorations are complete, the patient is set to an upright position and the assistant inquires about the patient's bite. The patient is pleased with the bite, and this is a picture of the completed restorations. We're going to briefly show the ISOLite system, not a commonly used system, but one that it is gaining popularity. It is a mouth prop, a cheek retractor, a tongue retractor, a suction system, and a light all in one. It requires special equipment. And again, not all offices have this equipment. The major difference for the assistant is the fact that the high volume suction is not required, although it is useful at times, so it should be maintained. But the assistant needs one hand simply to keep the mirror clean and then to rinse and dry the preparation when the doctor is not in the mouth. But again, the high volume suction is usually left in the holster unless needed to pick up large chunks of amalgam or eliminate overspray. So this is a summary of all of the steps that need to be gone through for a composite filling procedure. Start with topical anesthetic, completed with local anesthetic, either from the doctor or the hygienist, depending on which state you live in. Then the high-speed handpiece will initially prepare the cavity. Perhaps some dentists will use a spoon excavator or a low-speed handpiece to remove the cavity. The matrix band is placed. That's what keeps you from bonding to the other teeth. So you need to understand the tooth surfaces, the DO, the MO, the MOD. The metal matrix or clear matrix will be used, and a wooden wedge. Sometimes it's plastic. Some dentists are using just plastic wedges now. Etching gel. Some dentists may or may not use etching gel depending on which bonding agent they're using, but that would be follow as the bonding agent. And some are 2 steps and some are 1 step. It's just every dentist is going to have something different that they use. And the curing light. Some dentists will use flowable composite to fill in any voids. It's not recommended in many cases, but some dentists have figured out ways to do it. The composite is placed, then the matrix band and wedges are removed. Finishing burrs, the filling is shaped and polished, and then the bite is checked with articulating paper. And sometimes the bite will be checked between the polishing step and the finishing step. So the finish and shaping will happen before the articulating paper, and then following the articulating paper, the polishing burrs. That's a general overview of how most composite fillings will be accomplished. So I used the word occlusion. And what does occlusion mean? Occlusion means how the teeth come together. So if a car runs into a wall, the car has occluded the wall, right? We don't ever say that, but in occlusion, it's how the teeth come together. So you can understand what occlusion means. How should teeth come together? Well, that is the burning question. So sometimes they'll come together in many different ways. Malocclusion is a word that you'll hear. Malocclusion equals bad occlusion. Malocclusion may cause problems such as wear on the teeth. They can cause teeth to really hurt a lot. The teeth can be chipped. It can eventually cause tooth loss. It can make things hard to chew, make teeth very hard to clean. It can restrict movements and cause muscle pain and cause jaw pain. So there's lots of issues with malocclusion. Here is a patient that has severe malocclusion. You can see the teeth are crossed over each other in all different ways. Makes it really hard for this person to clean or chew or move around. This would be another example of malocclusion. The top front teeth are way too far out in front of the bottom front teeth. This is a side view of that same case. You can see how the front teeth are way out in front. So imagine this person trying to bite off a sandwich or something like that. You can see how this person has a stepped occlusion. The lower teeth come along, and then the occlusion steps down. So we call this stepped occlusion, where things just are really kind of difficult for the patient. And you can see there's a lot of wear and chipping on these front teeth right here as well. And this patient may have no pain or symptoms at all. They may think everything's just fine. They may feel that it looks just great, and that's fine. There's no reason to worry the patient except to inform them that this could continue to get worse. So here's a patient. This patient has some gum infection or some periodontal disease, and broken teeth throughout, and just really poor occlusion. So occlusions can be many different types. This would be healthy occlusion, overcrowded, an underbite where the lower teeth are out in front of the upper teeth, and an overbite where your top teeth overlap your bottom by a long ways. So here's looking at it from the side. The top would be normal occlusion. The bottom is considered class 2, and then, the middle is considered class 2. The bottom, where the lower teeth are way out in front, that's considered class 3. So malocclusion can be caused by growth issues and is often treated with braces, orthodontics. So in this particular picture, this is what's called an open bite, where the patient's back teeth are touching but the front teeth cannot touch. This particular one would be caused by thumb sucking, and very often, if it's treated, it'll be treated with braces. The problem with thumb sucking is it pushes the roof of the mouth up, it pushes the front teeth forward. Sometimes it will push the bottom teeth backward. There's just lots of problems with it. So the child really should be finished sucking their thumb by the age of 2 in order for it to not cause long-term problems. So another way to treat malocclusion is with Invisalign, or there are several different tray systems. One that's popular right now is Invisalign. Most people know what that is. There's a Smile Direct Club, which is people take their own impressions and order it, and they get their trays online without ever being seen by a dentist, and of course we don't recommend that. It should be supervised by a dentist or an orthodontist. So an orthodontist will start in the back by looking at the first molars. These first molars should line up in a certain way, and so the orthodontist will examine those first molars to help determine if the malocclusion is a skeletal problem, meaning it's a problem with the bones of the upper and lower jaws, or if it's just a position of the teeth issue. Obviously, position of the teeth is much easier to fix than problems with the bones. So in this particular case, the top teeth are overlapping the bottom teeth completely. This malocclusion is often called a deep bite or a severe overbite, but it is fixable. So in a typical situation, top teeth would overlap by about 25% the bottom teeth. It's about the correct amount of overbite. So just as a review, malocclusion, mal meaning bad, occlusion, how the teeth come together. When we do fillings, we've been talking about doing composite fillings. After we finish doing the composite filling, you want to fix the occlusion, make sure that things are coming together properly. A temporary malocclusion is created when you do a filling, and so the teeth need to be adjusted so that the teeth don't feel high. That's the most common way most patients describe it. A filling that's too large would be a high filling or a high crown. So the articulating paper is used, and that's what you're seeing here, these blue ink spots on these teeth are the articulating paper. Now articulating comes in a variety of shapes, colors, thicknesses. I prefer very thin, but some dentists use very thick paper. It's just everyone has their own method and their own preference on how to do that. It might be called bite tape or bite film or bite paper, articulating film or articulating paper. It has many different names, but whatever your dentist uses, that's what's important. As you can see here, the bite paper leaves marks. The articulating paper leaves marks depending on how the teeth come together. And being able to read those marks rather than, for instance, I would ignore these red little marks over here. I would pay most attention to these large marks. This tooth is probably the most high tooth in this particular picture. You see this mark here that is very dark, and it has a kind of a missing center, so like a donut shape. Those are the marks I'd pay most attention to. You'll notice there's a little bit of occlusion here and a little bit of occlusion here, but I would ignore these spots out in here because they're probably just where the paper is some of the ink is rubbing off more so than the teeth are actually coming together. So if you look here, this is one way teeth can come together. This is a more proper traditional way, and this would be another way that teeth could come together. But this would be the way that I would expect teeth to come together properly. So how do you adjust occlusion? It depends on why you're adjusting it and what material you're adjusting. So if it's a new filling, a smooth burr. If it's one of the newer crowns, the zirconio crowns, they're ridiculously hard, and so they require a diamond burr. So in this particular case, they're using a diamond burr to adjust these crowns. Probably the dental assistant should be using the high vac suction to eliminate dust, and the air water syringe to clean off the mirror and wash the mouth out. And the dental assistant is very often responsible for holding the articulating paper. This is something that I would recommend that you do as practice with your other students, practicing using articulating paper on each other and noticing how things work. You'll notice that of the two jaws, the top jaw and the lower jaw, the maxilla and the mandible, the maxilla does not move. The mandible, the lower jaw, moves. So I tell dental assistants it's much easier to hit a stationary target than a moving target. So hold the articulating paper against the stationary target, which is the maxilla or the upper jaw. So we'll go through a few things here. Folded paper is not good. It makes it too thick because you have a double layer. Wet paper does not generally mark very well, so I recommend that the teeth be dry. If patient has an overactive saliva or tongue, and sometimes using a very light, and I emphasize very light coating of Vaseline will aid in the marking. And again, as I mentioned before, always start by holding the articulating paper against the maxillary teeth. Why? Because those are the teeth that don't move. So don't try to hit the moving target. The lower jaw, the mandible, is always going to be moving. So how it might sound, and that doesn't mean the teeth snapping together, it means what do you say. And what I recommend is that you listen to what the dentist says. So close lightly on your back teeth. Good, now open, dentist says, and close again and grind your teeth slightly, and open, and close and grind nice and firm, tap, tap, tap. Good, and open. Perfect, now stay open while I clean off the marks. That's how it will sound when you're instructing the patient what to do. And I do recommend a strong, clear, cheerful voice. You don't want to sound commanding. You want to sound requesting and helpful. But listen to how other dental assistants say it and do it and what the dentist says. If you'll listen to the way the dentist says it, then you can know how the dentist wants it to be said. So a lot of times the dentist will leave the assistant to do the adjustment or to check the occlusion and let him know what it looks like. And so you need to be listening to the dentist to know how to instruct the patient how to bite properly. So if you learn the basics that you were just taught, you'll be able to adapt in any office that you work in. Some more on occlusion. Laboratories try to get crowns perfect. That's the idea. But human hair is 3/1000ths of 1 inch thick, and if this crown is even off by 1/1000th of an inch, the patient will know it. So, and that's virtually impossible for a lab to get a crown perfect every single time. Most crowns need some adjustment when they're delivered to the patient. So what if the occlusion's not right? Well, symptoms of bad occlusion or high dental restoration would be they're unable to bite, their teeth get sensitive to cold, the teeth, it may be one tooth or many teeth in either arch can be sensitive to ice cream, water, that sort of thing. It can cause jaw muscles and TMJ pain. The tooth may become loose and develop gum infection and periodontal disease around it. And it can require a tooth. It can actually kill a tooth and make the tooth require a root canal. So how do you fix a high filling? Generally, if the filling is left high by the dentist, or a temporary crown could be high,
A new crown could be high. It's very easy fixed, usually requires a couple of minutes. No anesthesia is generally required unless something is severely wrong. But you should interview the patient, examine the tooth, mark the articulated paper, inform the dentist of the history of the tooth and the symptoms that the patient's experiencing. Identifying what proper occlusion looks like takes practice and experience, and that's why I recommend you practicing on each other as students in your class, is to help you learn what good occlusion looks like. Marks should look the same on most of the teeth. The marks should be on the cusp tips in the middle of the teeth rather than on the outsides of the teeth. So for example here, in this example, I might adjust here and here as improper marks. I would like to see the marks up on the top tips and the middles of these teeth because these are the lower teeth. So I would adjust on the cusp tips. So this may be a bad mark, or it's often called an interference because it's going to interfere with the patient chewing properly. And it does not follow, this particular mark does not follow the rule of being on the cusp tips. This mark is a little off. You can see how it's down, not quite on the cusp tip, not quite in the middle, so it's kind of in between the cusp tip and the middle of the tooth, so it could be a problem, and I would probably make a light adjustment on that. This may be a bad mark or an interference again, because again it doesn't follow being on the cusp tip. This mark might be just fine. You see we're getting towards the front of the mouth on a canine tooth, and so it may be fine. You need to watch that particular mark as the other marks change. And you can see how these light areas here, this light red along some of these teeth, is probably going to be ignored because that's probably just where the paper just rubbed down the teeth, and rather than the top teeth hitting against these bottom teeth. So this mark is in the middle of the tooth, but is much darker, and meaning there's more color to it than the other marks. So the dentist is probably going to adjust this. And again, here we want it to be dark, but not too dark. So here's another example of what you might see. So I would like you to think about this for a second and tell me what you see. Think in your mind what you see, and I'll give you just a moment to look at that. Okay, so what I see here is close to the cusp tip, but on the outside of a canine tooth. This is a premolar, and I would like to see this mark maybe over here. This is probably the new crown that's being placed in the mouth, so I would like to see this closer up on this cusp tip. And this mark, you can see how this paper probably has blue on one side and red on the other, and the blue is starting to push through. This is a mark that I would find unacceptable, and I would probably remove this mark and this mark, because I would consider those interferences. So again, a donut-shaped mark indicates a heavy occlusion because the tooth is biting all the way through the articulating paper. So this is a new crown. I would make these adjustments here. And the different color of articulating paper might be used to help identify interferences when the patient is grinding. So anterior occlusion. So this would be like tooth number 8 or 9, and this would be tooth number 24 or 25. And looking from the side, as if we cut off the side, cut the person's face in half, and we're looking from the side. So the top tooth overlapping the bottom tooth, that's overbite, and how far it goes out in front of it is what we call overjet. Overbite is measured in percentages and millimeters, and the overjet's typically it can be measured in millimeters because there's no real percentage. There's no percentage in it. It's just millimeters. So in this particular case, the overbite is 50%. So I would recommend you turn to your partner or someone around you or your family members and evaluate their overbite and their overjet. Help understand that. So again, I want you to add articulating paper and flossing to your weekly drill practice, including suctioning air-water syringe mirror. Those are all things that you should be practicing now. So we'll talk about occlusion more later on in the course. I'm going to move now to a very common problem, tooth sensitivity. And I want you to understand how teeth work. A tooth can be sensitive because water actually is able to pass in and out of a tooth, stimulating the nerve endings inside the tooth. So if you look closely at this picture, you have the nerve and blood vessels inside. This is the pulp. And then you have the dentin of the tooth, and then you have enamel. The enamel is very dense and hard. The dentin is not as dense and not as hard. In fact, it's made up of millions of little stacked tubules, and the ends of those tubes are facing into the mouth. And so when the gum tissue is not covering the dentin, it can recede and expose those open tubules, and it allows water to move in and out and stimulate that nerve on the inside of the tooth. And it is very sensitive. So we're going to zoom in really close to the dentin and see that the pulp actually extends nerve fibers out into the tubules, and when that water moves through that tooth, it can cause that sensitivity. If you were even to zoom in closer, the powerful microscope view of the enamel, if we were to look at the end, these little tubules out here look like this in real life. Those are millions of little tubes. But that tooth is sensitive because that water passes in and out, and it can be very painful. Patients will avoid cold fluids. And this can be all the teeth or one or two particular teeth. Everyone's a little bit different, but those patients will avoid foods. Even just running the Dental Explorer, blowing cold air, or the Prophy cup or Prophy paste, or even topical anesthetic can cause a lot of pain. Dental assistants, they should ask the patient if they're sensitive before blowing air or water on the teeth or touching it with a Prophy cup. And be cautious, because they'll know if they've had their teeth cleaned before. They'll typically know. I have one patient that you can't even touch the side of his teeth with an Explorer. So he and I, over the years, have come to, he reminds me, and I remember now most of the time, that I don't touch the sides of his teeth with an Explorer, or he will just light up out of the chair. Extensive cavities or even small cavities can cause tooth sensitivity. Gum infection or periodontal disease can cause sensitivity. A million different things. Bacteria causes plaque, and plaque causes cavities, and cavities cause sensitivity. So if you remember this little Venn diagram from clear back in the first module, you'll remember that we have a susceptible tooth, we have food for the cavities, we have, food for the bacteria, and then over time, where all those things overlap, you will get cavities and sensitivity. And that's what plaque looks like. And you can see how the gum tissue is red and irritated and just not happy. And then over time, that acid from that bacteria eats holes in the teeth. But even without bacteria, teeth can still be damaged by what we eat. Now, these teeth can be maybe washed. The enamel, as you can see, is starting to be washed away or eroded away, much the same water erodes soil. Acid erodes the enamel of the teeth, and it can progress and become extremely sensitive to patients. So bulimia is an eating disorder where the patient vomits and a lot, and so that stomach acid can eat the teeth. Some patients have severe heartburn, gastroesophageal reflux disease, where the stomach acid comes up into the mouth, and it can erode the teeth significantly too. So this isn't a cavity. These can, and soda pop, energy drinks, citrus drinks. I had a patient that would he drank a lot of grapefruit juice, and it caused a lot of damage to his enamel. And these teeth can be very sensitive to temperatures, sweets, and they're highly likely to get cavities in the future. So here's an example of acid from bulimia eating off the enamel, off the insides of the teeth. You'll notice if you look towards the back, there's some erosion here, and there's almost no erosion here, some minor bits of erosion on the premolars, and then the canines forward have almost been, they've been almost destroyed by that stomach acid coming out and beating up those teeth. How do you handle hypersensitive teeth? There are many different treatments. There are many different methods. Every dentist will have their own preferred method. So I look for things like fixing high restorations, make sure that the bite is correct throughout everywhere, that the occlusion is correct. When I do a cavity, when I fix a cavity, if it's very close to the nerve, I'll make sure that I put an insulator between the filling and the nerve. Sensitive toothpaste are common. I don't recommend anything with tartar control or whitening because those toothpastes tend to be just more abrasive, and so I recommend that the patient not use tartar control or whitening toothpaste, especially if their teeth are sensitive. So you can apply bonding agents or sealing agents, and your dentist again will have his or her own preference on what sort of materials to use. Okay, so that concludes the restoration portion of today's lecture. Because it's so critical for you to be able to identify teeth on an x-ray, we're going to go through some practice there. So I'll help you, I'll point to a tooth, and then I'll give you a moment to identify it, and then I'll tell you what it is. X-rays have the bump facing you, so that's mostly for older x-rays. You don't have bumps on x-rays now with the digital films. They're usually put right into the computer, so that's kind of an older thing, but you may encounter it in certain places. So I leave it in here in these lectures just because there are still some dentists using the old x-ray films. They're fewer and fewer every day, and you may never encounter them, but in case you do, you know that there is a bump on them. So I'm just going to place the pointer on a tooth, and I want to give you a few seconds to identify that tooth. Okay, so that's tooth number 8. That makes this one tooth number 9, 10, 7. Can you see the cavity here? And this is the bump that I was talking about. So that's not a cavity, that's a bump. That's where the film helps you identify the front and back of the film in the old systems. Tooth number 25, 24, 23, 22. Tooth number 2, tooth number 1, tooth number 3, 4. Tooth number 19, 2 roots. Tooth number 19, 18, 20, 21. So sometimes computers even mess up and put the x-rays in sideways and backwards. So you need to be able to identify that. Here's the floor of the sinuses, so you know this is going to be a maxillary tooth. Number 14, 13, 12, 11, 15. Big landmark tooth number 11, 10, 12. Two roots, lower jaw, 19, 18, 20, 21. Tooth number 30, That would make this one 29, 30, 31, 32. This is a developing wisdom tooth. It's not erupted into the mouth, still covered with bone, has no roots yet. Tooth number 4, 5, 6, making this one number 3. Clues here, again, this is the floor of the sinuses, so you know this is a maxillary. 6, 5, 4. One of the few cases you're going to see where all 32 teeth are erupted into the mouth. So tooth number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. You see how 16 is rotted out. It's doesn't look great. Number 1 is undersized. Wisdom teeth are often misshapen. So this would tooth number 16, so this would be 17, 18, 19, 20, 21, 22, 27, 28, 29, 30, 31, 32. This is the TMJ joint. This is the sinuses. This is what gets all clogged up when you have a sinus infection. And right here is the eyeball, the orbit. Floor of the sinus. Tooth number 14, 13, 12, 11. Tooth number 9, 8, 7. This is the nasal passage of the nose where they breathe. 22, 21, 20. You see the large cavity here, amalgam filling. On tooth number 30. 25, 24, 23. Again, floor of the sinus. Tooth number 3. Okay, if we look carefully up in here, so we're looking at mixed dentition now, meaning mixed between permanent teeth and baby teeth, or sometimes called deciduous teeth. Our baby teeth are called deciduous teeth. So if I were to look at this canine, this would be the deciduous canine number 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Correct? So if I were to label the deciduous teeth or the baby teeth A, B, C, D, E, F, G are missing, H, I, J, K, L, M, all the rest are missing, R, S, T is missing, so 29 is going to come up where T would have been, and then 30, 31. Wisdom teeth barely starting to develop. You can just see the buds right here of wisdom teeth developing in this patient. Not every patient has wisdom teeth, most do. Again, floor of the sinus gives me a clue. We're looking at maxillary teeth, 14, 15, 16. Canine lateral 11, 10, 12, 22, 21, 23, 19, 18, 20, 21, 'So I'm going to assume this is 27, 26, 25, 24. Got a little chip missing out of it there. Again, sinuses up in here, very subtle, but things you'll start to notice. But that's the floor of the sinus, so this would be tooth number 14. You can see how tooth number 30, large cavity, getting close to the nerve. Number 19, cavity, close to the nerve. Missing the deciduous tooth here long before the permanent tooth is coming up. So tooth number K is missing, and it's a long time before number 20 is going to make it up there. And the problem with that is this tooth will tip into that space and cause malocclusion. So this tooth would be number 18. You may want to pause it and label those teeth in your mind. (27), 28, 29, 30, 32, 31, 30, and this is lying on its side, so it would be oriented 90 degrees to the right, like that. This is number 32. We have two roots on this tooth, so I know it's not a premolar, so that's how I know this is 30, 31, 32. Thank you for listening today. The idea behind recording these is that you can go back and watch them and listen to them as many times as you need. So I hope you've learned something today and look forward to having you join us again next time.